Hello everyone and welcome to what seems to be one of our most popular webcasts, coming to the end of breast cancer treatment. What now? Before we get underway, I would like to pay my respects and acknowledge the traditional owners of the land on which we meet here tonight, the Wurundjeri people from the Kulin Nation, but also pay my respects to wherever you are, to the custodians of the land. And I would really like to thank the elders, past, present and emerging, that are part of our network, and thank them for their continued contribution. You really are a very important part of our network. So tonight we are in for some great topics. I want to really encourage everyone to send through your questions to us. There are more than 1,200 people who have registered for this event, so I have no doubt some of the questions that you send through will be great. But so let's get straight into it. Normally I would make sure that I have a very long list of attributes for our speakers, but actually tonight, and I'm sorry to do this to you on the spot, but Belinda, I'm going to throw straight to you and ask you to introduce yourself because you are such an important part of our network too. So over to you.
Thanks, Kirsten. That's very kind. So my name's Belinda Yeo. I'm a medical oncologist here in Melbourne, and I also do some research. I guess most of the research that I do is really trying to focus on minimising toxicity of treatment and trying to really identify which patients need our most intensive treatment and which patients may be potentially spared some of those toxicities. So thanks for having us and look forward to some good discussion.
So do you want to go straight through to your slides about a bit of background and then we'll go on to our...
Yep. Okay, great. So thanks very much for those who sent in some interest topics, and that's really going to shape it. I've just got a couple of slides here, and this is just really, I guess, to start our conversation off. And these are the topics that many of you have sent in. I guess it's a summary of some of the issues that are really facing many women and some men in that period when the acute treatment, I guess we consider, has finished, and then we're in this period after. What happens at the end of that kind of first initial treatment? So the first slide is, what to expect after hospital-based treatment ends. And I see this as really there's good and there's not so good. So as many of you, I'm sure, will appreciate, there's less waiting, less coming to the hospital, less waiting. There's more time. So, having treatment takes a lot of time. So you've suddenly got potentially a lot more time on your hands that you may have had. The problem is that, when treatment ends, sometimes that's actually a kind of catch-22, because more time often gives us that perspective where when you're on acute treatment, particularly if it's something like chemotherapy, there are regular visits, there are, so much of your time is this new schedule that is unfamiliar. And then when that stops, oftentimes what I do is see patients where the actual diagnosis then really sinks in. And then there often is that time to really reflect on what has happened, what are the implications of that diagnosis that perhaps we did address and we did talk about in the beginning, but then we kind of put to the side because there's so many other things to concentrate on. So I think that can be a good thing, and certainly if we recognise that there's a reflection point at the end of your hospital treatment, it's a good thing, but sometimes I actually think it can bring up some more concerns. The other thing is, and I've kind of alluded to this, there's this loss of routine, and in a space like COVID-19 where we've all lost our routine, and I think we're all finding how to deal with, creating our own routines. Routine is often really important. And the routine of treatment can actually be quite a good thing to grasp on. It can give you kind of focus when, you're going through an incredible stressful period. But then loss of routine means that you need to create some kind of new routine. And that can be loss of a regular connection to your treating team. So, you have a lot of people around to support you in that acute hospital-based treatment time. And then suddenly it feels like that all just suddenly disappears. And so I think that can be difficult, and we might bring up some discussions about that today. A lot of the time I get asked this, so what happens after the acute treatment finishes? Like what happens when, my chemotherapy, I guess, is probably the best example, finishes? Who's going to be looking after me? Because many patients have met, and, this is just a number of people on the team, it's not an exhaustive list. But who carries on after that initial hospital treatment? And for some people, actually, everyone on this list remains a part of a very active part of the team. So, for example, there might be more plastic surgery to go, and oftentimes that's multiple appointments, maybe even multiple surgeries. And sometimes that's even, a year or, unfortunately, sometimes longer after your original diagnosis. Some of the team members tend to drop off. So, our radiology oncologists, they may give a short or sometimes not so short period of treatment. And then once they've assessed that the patient's perhaps not, hopefully not developed too many toxicities, they may be someone who drops out of the team. Psychologists may come in and out of that team. So what I find a lot of patients initially in their diagnosis, there's a lot of medical talk, there's a lot of medical treatment, and we talk about things like dietitian, exercise physiology, and psychology. And I think some patients do adopt those things from the beginning. Some patients adopt it throughout their hospital treatment, but really sometimes it's actually at the end of treatment when that really becomes a centre focus. So sometimes the follow-up team is a little different to the acute hospital team, but sometimes actually all of these people. And I think one thing that we really recognise is that, the GP is often sadly left out a lot of our discussions. And again, and I think I'm probably going to bring up COVID a lot tonight. One fantastic thing is GPs can't turn up to all of our meetings. They can't turn up to our multidisciplinary team meeting when we discuss every case because they don't, no one has the ability to jump out of their rooms, drive up to the hospital. But in fact, because of COVID-19, we've got this new IT capability. And wouldn't it be fantastic if we could have the GPs of patients be able to, tap in? And I think we can do this, and some places certainly do this better than others. So hopefully we can actually bring the team together from the beginning very early. One big discussion that, I spend, I think, most of my time talking about, surprisingly, is not the toxicity of chemotherapy. We spend a lot of time, but it's actually more the toxicity of hormone treatment, or in fact, it's really anti-hormone treatment. It's taking away the hormone drive in the way we do it with our drugs. And one of the key things that, really confuses people, and, to be frank, it confuses doctors, family members, patients, is, who needs what drug and for how long. And the reason this is confusing is because the data is not that straightforward. So, and it all comes down to the individual patient that is in front of you, talking about her cancer, talking about her comorbidities, talking about what is acceptable for her, and also not actually knowing before you start these treatment what's the toxicity in the individual person in front of you. Some people surprisingly get away with very minimal side effects, and other people have a lot of side effects. And so this is what we often spend a lot of time talking about. And, what frustrates a lot of patients is that if they see 100 oncologists, and I often say that, what if you saw 100 oncologists? We all say the same thing. But oftentimes we don't all say the same thing. And I think that frustrates people. Why can't you all think the same? And when I talk to patients about that, I say that, look, if you saw 100 oncologists, and some of us would think this way, some of us would think another way, the reason is it's probably because the data is very on edge. The data is probably marginal. And what I mean by that is the difference between our treatments might be pretty small. The potential toxicities might, though, be really great. And so if you're talking about a really small benefit, but a drug treatment that just, a lady cannot tolerate, then that really small benefit may well be far outweighed by the toxicity. And you often don't know that until you actually try. So these are the type of things where I think after the acute hospital treatment, particularly because the vast difference between something like 3 or 6 months of chemotherapy, or, 6 weeks of radiotherapy, or 1 day of surgery, if you're lucky, is very different to 5 years of tablets, or maybe injections, or even, sometimes longer. And that question of sometimes longer, I think we might talk a little bit about tonight. So apologies for the acronyms. This is a very simple and by no means, didactic way, but sometimes this is the way, I guess, as clinicians, we think about what are the choices with endocrine therapy. Because what many patients have heard, and it's out there in the media, is that you need 10 years of these drug treatments, or sometimes people say you need them for life. And there are some cases where patients do need these for long periods of time. And I have to say, even a patient I saw today, she's in her 13th, 14th year, and there's no way she's going to let me stop it. This is her, this is her kind of security blanket. Fortunately, she's tolerating it really well, and I'm not going to stop it in her, So this difficulty between how long you use the drug and for, which drug you use, there are more well-tolerated drugs. So tamoxifen is our oldest drug in breast cancer. We've had it around for the longest. We talk about targeted therapy. In fact, I would argue tamoxifen is probably the first targeted therapy and still a very good treatment for breast cancer. What tamoxifen does is it doesn't take estrogen out of the patient. It actually leaves it there, but it just blocks it at the receptor level. So if you think about our endocrine treatments, they're a bit more gentle if you think of tamoxifen versus something like the aromatase inhibitors, because what they actually do is they stop a postmenopausal lady being able to produce any estrogen. So we're not talking about the ovaries here, because postmenopausal ladies, they don't have ovarian function, but we're talking about estrogen in other parts of the body. And so these drugs stop the enzyme that allow you to convert the pre-estrogens to estrogens. And so you can kind of hear it. One leaves you with the estrogen that creates a little blocker. The other takes any residual estrogen that you can produce out. And that's why there's often a difference in the side effects. And so when we're thinking about what to do in the first 5 years, the main question you need to consider is this a premenopausal lady? Is this a postmenopausal lady? And there are some ladies in between where we render them postmenopausal because of treatments like chemotherapy. So without going into too much of the detail, and I'm happy to answer any questions about this, they're the kind of discussions we have. And when we're thinking about what treatment we need to use in the first 5 years, it does come down to, well, what was the cancer like? How driven by estrogen was this cancer? And is this a cancer where, yes, the risk is high that it might come back? There were several lymph nodes involved. It was a bigger high-grade cancer, in which case we would try, if we can, the more aggressive therapies. But, I say this all the time. The best endocrine therapy, or the best hormone therapy, if you like to think about it, is the one the patient can take. And we don't always know. In fact, we never know the answer to that question when we first start them. But that's certainly something that we learn along the way. And everybody is learning that. The patient is learning it. Family members and friends are learning it. And certainly we as clinicians are learning it. I think you really have to listen to your patient to hear how this drug that you may have given hundreds of times to other women is working in the patient that you've got in front of you. The next 5 years is a lot more difficult for me to answer in one slide, because the next 5 years, really the data is actually a little bit messy. So for some of our drugs like tamoxifen, more tamoxifen appears to be better than less tamoxifen. For the drugs, the more intensive drugs like the aromatase inhibitors, actually it turns out that the longer you give them, they don't necessarily give you a lot more benefit. And so there's something about that. And the way I kind of think of it is, maybe the most potent drugs you just need at the beginning because they've done all the work that they're going to do. Tamoxifen has this amazing ability, we call this carryover effect, where even when you stop it, it's still actually working for potentially years even after you stop it. And that's in fact why these drugs also work very well to prevent breast cancer. So the first 5 years, might seem a bit more straightforward. The second 5 years is often a really difficult one to answer. And again, for me, I'll tell you what, the patient usually decides it for me, because the patient who's been on a drug for 5 years either comes in, hands the box over and says, Belinda, it's been great to know you, I'm out of here. Or they actually take that back and say, I don't care what you say. I don't care whether you say to me that this has got a really minimal benefit. For me, this is a security blanket. I'm tolerating it well, and I'm not going to let you stop it. And of course, there's people in between where I might be saying, look, I think longer is going to be better. Do you think we can go for longer? Can we do something about these side effects? But 5 years is already a long time. And so patients usually and hopefully have warmed into a state where they've been able to tolerate the treatment, and maybe we've had to do multiple things to make that more tolerable. And of course, what happens in 5 years, a lot of women are aging in that time. They may be going through menopause in that time. They may be getting used to menopause in that time. And of course, our drugs don't always make that easy. So the first 5 years, I think your clinician might push you through. The second 5 years, I think, hopefully, I think for me, the patient, even if before the patient walks in the room and I'm trying to make a decision, the patient usually decides it for me. I think you guys can talk to this much better than I can, but, it's not just a physical recovery. There's emotional recovery. And I think, there's many forms of recovery. And it's easy for me to sit here and say, of course, this starts from the day you're diagnosed. But that's, a much easier thing to say and a much harder thing to do. I think, I certainly would say you look, and this is throughout treatment, you look for the supports that are available to you, and you pick the ones that are going to suit you. Because lots of us, we might have a smorgasbord of things, but, if you've never, swum, 200 meters in a swimming pool, swimming's maybe not your thing. So, suddenly telling someone to jump in the pool in the middle of winter, I wouldn't do that. So I think you've got to find things that really suit you and suit your lifestyle. And in this follow-up period after, I guess, acute hospital treatment, there might be specific priorities that are important because of the treatment, because of what the treatment has caused. And then, of course, there may be things that were there even before breast cancer was diagnosed, but if we've kind of pushed to the side because the breast cancer diagnosis has been the biggest thing. So, bones, really important because of the importance of what estrogen does to your bones and the loss of estrogen, or when we hide estrogen from the bones. Muscle mass is really important. I mean, exercise is, it goes on the script. Hard to do, but goes on the script. And, keeping muscle or gaining muscle is important, not only because it improves your cardiovascular fitness, which is still important for breast cancer, but it'll improve your tolerability to our treatments as well. Weight gain. So, a lot of women do worry about weight loss during our acute treatments, but in fact, weight gain we know is a really big problem because of our treatments. And, what we like to try and do is to prevent weight gain during treatment. And certainly, losing weight is a really difficult thing for many of us to do. I mean, there's no magic science to losing weight. It's a really difficult thing to do. And I think when you're kind of fighting an uphill battle with drugs that may make that more difficult, sometimes the priority cannot be there in the acute hospital treatment phase. Other things like, this sounds like a really bad slide. Look at all the things I do. Cholesterol can be affected and menopause. And I say not just menopause, because some of the drugs we do, take estrogen away even more than menopause, even more than, 80-year-old ladies out there or people who've had their ovaries out. Our drugs actually sometimes take even more estrogen away. And, things like smoking cessation and making sure that people are not drinking excessive alcohol are important in this, road in recovery. And I guess also really trying to minimize the risk of breast cancer recurrence, because as clinicians, we really do continue to focus on that because, we don't want this breast cancer to ever come back. I think this is just a slide to say that, sometimes our priorities change when, we get a breast cancer diagnosis, and sometimes they change during the treatment. And, our priorities can change at any point, at any point when we're diagnosed with something. But I think acknowledging that, what was maybe important to me at the beginning or maybe important to me when I finally, left that chemotherapy room and that was it and I didn't need any more treatment might be different to what happens a year down the track. And so I think just being able to acknowledge that, it's okay if people's priorities change. I think that's okay. And just working out how this might fit into, your work lifestyle. If you're working through treatment or, returning to work, how does this fit with my family or friends? So these are the kind of considerations that we make. So they're just a couple of pointers that hopefully will spur a little bit of discussion.
Thank you. And thanks, Belinda. And the questions are coming through, so please continue to do them. We're going to address them next. But it's now my great pleasure to welcome Corella Hoogendoorn. How'd I go?
You did really well.
Awesome. Thank you. It's honestly the most stressful thing about hosting these events is making sure you can get people's last names correct. So Corella, thank you so much for joining us. Can you tell us a bit about your breast cancer experience?
So my breast cancer experience started in August of last year. I was diagnosed with HER2 negative, estrogen receptor positive cancer. I went on to have a lumpectomy, and then I was followed by 4 rounds of chemotherapy, TC, and then 5 weeks of radiation. And I completed just as COVID was hitting our world. So, yeah.
Wow. And so tell us, what was that like? Belinda spoke a bit before about when treatment finishes. What was that like for you, the day that treatment finished?
Yeah, it's really interesting listening to Belinda because I can see there's a lot of things that, have overlapped with what I think is, but the emotional was a big part for me. I think throughout treatment, you are continually just worrying about, you're sort of in survival mode. Mm-hmm. You're worrying about, you just want to get the cancer. You don't really think about the emotional. But on the last day of my radiation treatment, I actually found myself feeling what I thought I would always feel, elated and relieved that it was finished. I was actually quite sad because I actually didn't want to leave. I almost had separation anxiety because I didn't want to leave the care of my doctor, because for some reason I felt like if I was under his care, the cancer couldn't come back. So I actually felt emotional, but it was not the emotion that I thought that I would feel.
So what were some of the strategies you put in place to help you deal emotionally?
So when I finished treatment?
Yeah.
So when I finished treatment, I was very aware of my emotional state when I finished. And one of the first things that I knew, I was very lucky, and we spoke about a GP. My GP was very good, and he said to me, how are you coping emotionally? And throughout treatment, no one really asks you, how are you going emotionally? Or you don't really talk about it even, because it's survivor mode. I want to get through my treatment. I want to get the cancer and have the best result. So the strategies I found to help me cope with the emotions was, I sought out very early on when I finished treatment is to see a psychologist. And I found that personally helped me immensely. I found that throughout treatment and throughout even after treatment is finished, it's very hard to talk to someone. Not everyone experiences this. So I found that talking to psychologists, it really helped me because it was a safe space for me to talk and feel that I could share, and someone who could help me with strategies. And I think that's really important, is that just to know that it's okay to feel like this and to feel emotional, but to have, some strategies to help you and to not feel alone.
Yeah. Annika on the questions has come through is, how do you manage the new normal? And I think the first part of that is actually identifying that life is not going to go back to where it was. So how have you kind of dealt with that, the new normal?
Yeah, the new normal, that's an interesting, that's something that it took me a while to adjust to, even that there is a new normal. I think I was a little bit in denial, where I thought I would just slip back into the old me, but that doesn't happen. And whether, that's because of the side effects from treatment or whether that's the emotional. But how have I coped with my new normal is, I think it's important to know you're not alone and that there's people out there you can talk to. So yeah, that's how I would answer that.
And I also think that lots of people need to talk with their family about it.
Yeah,
because,
absolutely.
We constantly talk about it, that the treatment finishes, so do the meals at the same time, or the helping to pick up kids, or the family doing the housework. And they kind of, I describe it as handing back the vacuum cleaner.
Yeah.
And it's like we need to teach everyone around the patient that life is not going to go back for the patient or for them to how it was before. Is that what you've kind of experienced?
Yeah, absolutely. And I think, it's exactly what, a lot of patients describe that to me, where, this analogy might seem terrible, but, there's an exam and you think, I just know that the next day everything's going to be all right. And then the fall is great because it's not as you thought. And I think that it's good to, be a bit prepared that might be the case. Did you find it easy to get help? Because I guess in my experience, I think oftentimes, it is hard to find where the help is. And especially at the end where, at the beginning, there's this whole team around you and everyone's there. And then at the end, as you say, people kind of fade away. I mean, you said your GP was very good, which is good.
And I was very fortunate. I had a GP who was very empathetic and asked me how I was going emotionally. And I think when he asked me, it was very confronting because no one had ever asked me that. So I think he was immensely supportive. And I think, unfortunately, not everyone has that support with their GP. But, I think it is important to have a support network, and whether, and I found immense support even just in fellow breast cancer patients who can share, this is a very isolating and lonely journey because, not everyone experiences this. So I found also talking to someone else who's been through it helps as well. And I think, Kirsten, what you were saying about family is really, and sometimes that can be tricky because, you don't also want to burden your family too much with the emotions, because then they also feel upset. But I think it's very true what you were saying, Kirsten, about the fact that everyone's very keen for you to return back to normal. I recall, like, first week of finishing treatment, my husband was like, okay, so we've got this and this and this on. And it's like, whoa, hold on a minute. I'm not sure if I'm quite there yet. So it takes time.
Yeah. And I think getting access to things like the mental health plans, and if there is only one message that people take home tonight, it is that a GP is absolutely essential part of your care. And the silver lining, I think, is what you talked about before, Belinda, about GPs are now becoming much more involved in a cancer patient's diagnosis through technology. And so if you don't have a GP that you trust and that you really connect with, it is time to find that. Now, that is much easier said than done, particularly for regional areas where we know there is a high turnover of GPs and also this corporatisation of GPs. So I think if you can find someone that you really connect with and can understand your own experience, because they're not just worrying about you from a medical perspective, they're worrying about you holistically around exercise and linking you into programs, because nothing annoys people more than finding out about a program after they've needed it. It drives everyone mad. So just staying on this emotional, and I should say that BCNA is going to be doing another webcast around with a psycho-oncologist who can really talk about this in more detail. But every time we do a member survey, over 80%, the greatest fear is the fear of recurrence. Belinda, talk us through, how do you relieve that fear of recurrence, yet communicate that there is the reality of breast cancer coming back for many people?
Look, it's really tough because breast cancer, I can give you the stats and I can tell you that, 8 or 85 out of 100 women are going to be cured from breast cancer. And, people walk out of the room and say, well, those odds are really good. And yet breast cancer can be unpredictable. And we hopefully do our best, and we don't always do it right. But hopefully it's about trying to weigh up where you feel that the patient in front of you, you want to be realistic and you want to be optimistic at the same time. And you can't just say, don't worry, it's never going to come back, so, see you later. Because the reality is, even if you think that, even if this is the smallest breast cancer that you've ever seen, the truth is, in that lady, this has probably been the biggest threat to her life to date. And, you always have to remember that. But at the same time, you don't want to leave them thinking, the fear is great, because the fear, that it will come back is probably not great. One thing I like to use, is that the drugs we use, particularly in estrogen-positive breast cancer, which is most of the breast cancer we see, if you've been diagnosed with a breast cancer, we often say, well, the risk of another breast cancer, I'm not talking about if there's a gene fault, but the risk of another breast cancer in someone might be a bit higher than the background population. And yet the endocrine therapy, or the hormone tablets we just talked about, actually reduce that risk. So a lot of the time I'm sitting with patients saying, well, look, your risk of another breast cancer might be a little bit higher than mine, but actually if you take the pills, they actually fall to less than mine. And that kind of information is not easily out there. It's not easily, you can't pull it out of a paper. But the truth is, they also happen to be very good drugs to reduce risk. And the other things like lifestyle and things like that, if this is a point where, smoking cessation, I mean, we know we shouldn't smoke, but this is a point where this is the best reason in the world to stop smoking. Then, you can make kind of lifestyle changes that maybe the breast cancer diagnosis without it wouldn't have been there. So it's balancing up being honest. I think you've got to be honest, because sometimes that risk is significant, and I think also what you've got to instill in patients is that, the frustrating thing about breast cancer is there's nothing to measure, right? I mean, after we've given the treatment, you've just got to wait and see, right? And I think it's about having a relationship with your clinician, whether that's your GP or, it might be your specialty team, to say that if you're worried, I want you to come back. That's the whole point. Because if you come back, the likelihood is I'm still not going to find the breast cancer, but I don't want you sitting at home or out there thinking, is this it? Because that's our job. Our job is to work out, is that worry founded? And, have we found a breast cancer recurrence? Or can I relieve you of that in whatever way it might be? It might be just seeing you, or maybe telehealthing you. It might actually be doing a scan to reassure us. So empowering patients to know that we are here. And I think we can do a lot better job. And, again, in these times, we've got to be more, I think we're getting better at communication. Hopefully we're getting better at communication, even just with things like the GP. Like, I did a call with a patient's GP who's in the Northern Territory. I've never been able to do that. I mean, maybe I could and just never have done it. So I think it's on us to make sure that we communicate a bit better. But that's the one thing I would say is that, if you're at home and you're worried, we want to know about it, because, we don't scan you when you're well. We don't do things when you're well. So if you're worried about something, it probably means you need to see it.
So let's talk about that scanning when you're well.
Yeah.
Because from a patient's perspective, it makes no sense to not scan. Like, we're screened when we're well for breast screening. But yet you've been diagnosed. Don't worry, we're not going to scan you regularly because there's no reason to. It makes logically no sense. So try and make sense of it for us.
So this is a good one. Good question. It's early in the piece, but okay. So the truth is, the reason we say that, so not talking about breast imaging. Breast imaging is important after a diagnosis of breast cancer. So we image ladies for every year for X many years. But this idea that if I scan you from head to toe every year for the next however many years, that actually doesn't make a difference. So the data so far, and I'm going to caveat this because I do think this will change, but this is not for you all to go out and get CT and bone scans. But I do think this will change, and I'll explain why. The data so far says that if I looked at all my ladies with early breast cancer that I've treated, and I said to you, all right, let's do a CT scan, bone scan, PET scan every year, every 6 months for the next 5, 6, 7, 10 years. One is, with some of those scans, I'd probably cause more harm. I would definitely actually cause more harm. And the harm is not just about radiation. People worry about that. That's probably one consideration. But it's also about doing a lot of investigations for something that never turns out to be breast cancer. But the data would suggest that there's actually, you don't live any longer, and this is hard to hear, but you don't live any longer if I scan you every year for the next 10 years and find the breast cancer come back, versus if you turn up to me and say, you know, I'm worried about this pain and it turns out to be breast cancer. You don't live any longer for that. So what I mean by that is if you present with a symptomatic recurrence, where you have a symptom and I find the breast cancer come back, it actually doesn't change the outcome for how long you live if I found it out of the blue. Now, the reason I think if you record this and take me back in 5 years, maybe less, is because we are getting a lot better at treating very small amounts of disease when it comes back. And, you know, we say we don't cure metastatic breast cancer, and that's not the byline, it's not the topic today, but I tell you what, we do cure some women. And I know that as we get better and better at detecting recurrence earlier, as long as the treatments we give when women are well don't make them really unwell, I do think that that will change. Now, is it going to mean a CT scan every year, every 6 months? No, I don't think it will. Hopefully it'll be a blood test, or hopefully we'll think of something, you know, even more clever than that. So at the moment, that's the data I talk to patients. And having said that, you know, if you've got a patient in front of you or had something a bit funny on their scan at the beginning and they come back and they say, Belinda, how do you know? How do you know? You didn't stick a needle in. How do you know? You said it's a liver cyst. How do you know? I don't think there's anything wrong in that patient having that discussion saying, look, if you want to scan at 12 months to reassure you, that's fine. You know, so there's what we do, what we talk about with evidence, and then there's the patient in front of you. And I'm going to keep coming back to that because everybody is different. I mean, we are all really different. So, but I hope that, you know, one day I can tell you, you know, actually, you know what, we will be looking harder than we are at the moment. But that's why at the moment, if you hear it from your doctors, the data is true. You know, CT scans every 5 minutes actually don't change the outcome.
So, Corella, how are you kind of dealing with that?
So that's really interesting, Belinda, because that was something that really surprised me when I finished treatment, because I thought, okay, so when's my next scan? So you can tell me that I'm okay, so I can live by these scans. And then my oncologist gave me that similar advice, and it took me back a bit because I was like, okay, so where do I go from here then? So I mean, I'm still very early on. I'm very fortunate for me with the whole recurrency anxiety is that my oncologist nurse gave me some valuable advice, and she was like, for the first 12 months, more than likely any minor pains that don't last more than a day is probably related to treatment. So I think that has kind of calmed me a little bit, but I would be wrong to say the thought doesn't enter my mind. It's just about learning strategies and thinking to yourself, okay, is this really something, or am I just, is my mind actually jumping the gun? And it's easier said than done, but for me, I'm still learning every day how to deal with it. So I don't have the answer, but seeing a psychologist has helped me immensely, because cancer anxiety, I've understood now, is a real term. And a psychologist has helped me with just strategies on how to, you know, not go to a GP every week and say, I've got this pain. What does this mean? Does this mean the cancer's back? So,
but also I think, you know, hopefully that the team is there then, because it isn't really your job to say, could this be the rest? You know, I mean, you're right. You do need those strategies that, you know, if every single time we all have an ache, we all are going to get a cold or a cough. So I think, you know, part of having a team is to provide that reassurance. And that reassurance might be having someone see you, or it might be talking through it with a psychologist, or it might be, albeit, having a scan, you know.
And I think it is on that, Belinda, it is important that don't be afraid to ask. I feel like we finish treatment and we think, oh, I don't want to call again, but I think it's better to call, and whether that's your GP, whether that's, you know, your oncologist or your breast surgeon, is just make an appointment or ask the question. It's better to put your mind at ease than to, you know, play with your mind and, you know, start thinking the worst case scenario, because we all know that stress isn't great either.
Yeah. So there's quite a few people coming through around triple negative, and I think Marianne's question kind of sums that up, is how do you manage the risk of recurrence for triple negative breast cancer when there's no therapy to reduce the risk?
Well, the first thing I'd say is that there are therapies to reduce the risk of breast cancer, but I think what you're alluding to, Marianne, is that we don't have those endocrine treatments we talked about where there's ongoing tablet treatment to kind of, you know, I guess be this kind of blanket treatment for years to come. The thing I would say about triple negative breast cancer, which is different to the ones driven by estrogen, and this can be a two-edged sword, is that the risk of it coming back tends to be in the first few years. Whereas with estrogen positive breast cancer, that risk is something that carries on for many years potentially afterwards. So the one thing about triple negative breast cancer, and I do say this to patients, is the further we get away from your diagnosis, the better. And that is true, because if you get through those first 3 years, the likelihood of it coming back late, so, you know, after 5 years we say late, is actually pretty low. So that's one thing, whilst you don't have, I guess, that insurance policy tablet. The other thing is you don't get the side effects of the tablet, you know, so that can be, I guess, a positive. But, you know, triple negative breast cancer, let's be honest, gets a bad rap. Go and Google it. It gets a bad rap. But there is triple negative breast cancer that does extremely well. And so not every triple negative breast cancer is a breast cancer that's going to come back. And that's a really important message as well.
And there's also been increasing investment in the research
Absolutely.
aspects of triple negative. And when we go to some of the big conferences,
yep,
a lot of it is around the triple negative and some of the advancements.
And I mean, I guess this is not about immunotherapy, or we'd have 5,000 people on the call. But you know, I think if we're going to get immunotherapy for breast cancer, we haven't quite got it off the shelf yet. But you know, I think it's going to be in triple negative breast cancer. So yeah, we've still got work to do.
Yeah. And in fact, it's being led here in Melbourne with some of the work out of Petermac.
Yeah,
so,
absolutely.
Yeah. So tamoxifen, is it useful for men who are diagnosed with breast cancer?
Yes, tamoxifen can work for men. It's often actually used most commonly for men. So the other medications, the aromatase inhibitors, we sometimes use in men, but it's a little more complex. So yes, tamoxifen would be a very common treatment to use in men with estrogen positive breast cancer.
We had a webcast a little while ago on endocrine therapy, and there was quite a lot of outrage afterwards about the lack of investment in dealing with the side effects of the endocrine therapy. And also this kind of notion of exercise is going to fix it all. What do you do? And you talked about that communication with your oncologist, and obviously you are an excellent communicator. What is? I think so.
No.
But what do you do if you, as a patient, are feeling like your oncologist is not listening to you around the side effects? What would be your advice to them? Because we know there's some pretty poor communicators in the
There's
health
a lot
profession.
of poor communicators in the health profession. I mean, and I think, you know, even the good communicators, we don't always, you know, get it right, or we're short of time, which is no excuse. But I think when you're talking about endocrine therapy, for me, the most important discussion is that first discussion, because sometimes we're talking about treatments that might cause a lot more side effects. And then we think of the treatments like tamoxifen as, tamoxifen is never going to work, so we're not going to use tamoxifen, which is absolutely not true. We're talking about treatments where they might have slight benefit, but if the side effects are much worse, that benefit may not be in there, because we don't actually know whether there is any real meaningful benefit in you, the patient in front of me. So that first discussion where we say, these are the treatment options we've got, and we might have to change along the way, and that is going to be okay. I find it really hard when you meet a lady 2 or 3 years down the track and she's having a terrible time, and you say, do you know what, I've got a solution. I've really got a solution here. And she goes, there's no way, because someone told me 2 years ago it didn't work. And so I think, you know, I do think, you know, having a good communication, and also the story is not always easy. You can have a list of side effects and you haven't even taken the pill yet. And then you might actually find that it's the rare ones that might not even feature on the list that you have. And that's actually really important, because coming in and maybe changing the time you take the medication or what you take it with, or actually changing even the family of medication but keeping the drug the same, makes a really big difference. So, I mean, I think we like to see people after you've been on the medication. That first few months on the medication tells a lot.
And it's not pleasant always.
And absolutely. And yet, at the same time, you know, I think there's also patients where they will drive through that first year no matter what. They'll go through hell to do this, and then maybe the priority has changed and then that's another time. So I think, again, I mean, you know, most things come down to having a good relationship with your team.
Absolutely. And I think on that, Belinda, is that I think don't be afraid to speak up about the side effects, because I didn't know that there was something for the excessive hot flushes. There's a medication available to me. So I was like, great.
Yeah.
So I think talk to your doctor and let them know how you're feeling, and that if you're not coping, call them and say, look, I'm not coping on it. What else can we do?
And we are terrible. We underestimate side effects all the time. We do, particularly with endocrine therapy. I mean, that's absolutely true. So I mean, we have a whole clinic where we have a bone doctor in the room next door. Like, I mean, I think, you know, it's easy when you're focusing on one thing and like you see 40 patients, whereas oftentimes you're seeing lots of different things, and, you know, and you might only have very short amount of times with your GP or your oncologist or your breast care nurse. So, you know, sometimes these things take a few visits. You cannot solve these things necessarily in one 15-minute consultation. So, you know, I think, you know, don't wait for the doctor to ask. That's the other thing, you know, particularly when it comes down to like sexual side effects, like vaginal
Definitely
dryness,
don't wait for them
you know,
to ask.
so because they won't ask you, you know,
No.
you know, assume no news is good news. You know, you look well, you know, I can't feel anything. I mean, that's not, you know, and that's not to put it all on the patient. It is our job, but, you know, we hopefully can help you. And if we don't know how to help you, we should send you to someone who does. Because we've got teams, you know, we've got menopause specialists. I mean, you know, so it doesn't always have to be the person that's been looking after you for the last 2 years to be able to help you solve the problem.
So, Corella, how are you coping with some of the side effects like hot flushes, which I think has just entered into your life?
Yeah, it has, and it's amazing not. But it's definitely very debilitating. Like I think that's what I didn't expect. I thought I finished treatment and I go off on my merry way. I didn't realise that these side effects, you know, still continue, and there's the emotional, but there's also the physical. So it's definitely a struggle. And I would say in some ways, these side effects are even worse than the actual treatment, because you know that treatment's coming to an end, whereas the side effects, I don't know how long I'm going to live with the hot flushes. So I'm learning every day, but, you know, I'm communicating with my oncologist and saying, look, I'm not coping. I'm dealing with 8 hot flushes a day, and, you know, it's affecting my life. And so I've now taken another medication to try to help with that. And so I think the thing is, when we finish treatment and we say, okay, when am I seeing my oncologist? I'm seeing him at 6 months or 1 month or whatever. I think don't be afraid to pick up the phone and say, look, I can't wait till my next appointment. It's not working for me at the moment. I'm struggling. Ask for help. I think it is my advice, because that's what's worked for me. Am I coping with the side effects from tamoxifen? Probably not, but it's just about learning my new normal too, and learning at, you know, what works for me, and, you know, exercise helps side effects. So it's a trial.
And I mean, the only thing, we're nearly out of time, but the only thing I would say to defend the clinicians, a little like bag them out a little bit, this webcast, but is that we don't always give you the full smorgasbord on the first day. It's a little bit like chemotherapy. We've got a bunch of drugs to stop you being sick, but if you do happen to be sick, I've got more to add. And it's a little bit like endocrine therapy, like you just said. I didn't know there was a drug that might help the hot flushes. And you might say, well, how come they didn't tell me that at the beginning? Sometimes we do wait and see, because, you know, going through a discussion about another drug that might cause other side effects, you know, so sometimes you haven't heard everything the first time. And so it is a little bit about, you know, there's a lot of information, and remember, the data's changing all the time. You know, we're getting new drugs all the time. So, you know, they may not have told you everything. It's not because they're being malicious or anything. It may just not have been relevant at the time.
No, and you don't want to overload a patient either and give them every side effect when it may not be relevant either.
Yeah.
And I know we're out of time, but I know it goes quickly, and there's so many questions coming through. So I'm sorry to people who we've not been able to address some of your questions. But I think this one from Catherine is really important to Corella. How have you made ongoing lifestyle changes since your diagnosis? And I know there was another question earlier about the use of alcohol, and really, you know, some of the data that's coming through around alcohol. So what are some of the lifestyle changes you've kind of reflected on post a diagnosis?
As in just in regards to the side effects, or in relation
Just your
to
life? What?
Look, I would love to say that I have got a new lease on life and I'm living life to the fullest, but I'm still, trying to work out what my new normal is. So I don't really have that answer. I'm just learning every day, and I just know that there are people there to help me. And just, all you can do is just get up the next day and just try to face it and just get through it.
I think that's a really important point to finish on, actually. And that is because so many people think they have to put the mask on, and Raylene Boyle talks about this all the time, that you have to put this mask on and tell everyone you're fine once treatment's finished.
Yeah.
But in actual fact, it's when many people's lives simply fall apart and they don't know how to reach out for help.
Yeah.
Whether it's with their medical team and to understand what access programs. I know there's questions about where do you find recovery programs, and there are lots of opportunities that exist, and it's about going to a trusted source to then be able to help you navigate the system. And I think that's the really important role that BCNA can play for you. So calling our helpline on 1800 500 258 to help you navigate and get access to recovery programs, access to government programs, because we absolutely know the financial burden just keeps on coming. We haven't even touched on lymphedema tonight and the impact that lymphedema still has on Australian women long after their breast cancer treatment has finished. So we really want you to access BCNA, our My Journey online tool, but also our helpline, so that we can help you find the right places for whatever your need is. So Corella, Belinda, it always goes much faster than we think, but you are both absolutely brilliant. I would encourage people to register for our next webcast that comes up around the emotional side effects of breast cancer, and really utilise this time right now in accessing the very best psycho-oncologists through telehealth, because I think there is a very big distinction and a different approach you will get to accessing counsellors who are experienced and knowledgeable in the cancer space, because I think your needs are quite different. So from all of us here, thank you very much. Please call our helpline 1800 500 258 for any help you need. And the My Journey online tool is there not just for people newly diagnosed with breast cancer, but for all of your life after information and support as well. Thank you to the team who have put tonight together, and we look forward to seeing you very soon.